We are midway through a phase 1b clinical trial of adding pembrolizumab to tisagenlecleucel infusion in patients with relapsed refractory diffuse large B-cell lymphoma. And I'm happy to discuss some of our results today. This study is called Portia. All of the CAR T-cell studies in the Novartis pantheon are named after characters from Shakespeare. We're all waiting to be part of the Hamlet study. Portia looked at the potential benefit of adding an anti-PD-1 antibody to patients being treated with CAR T cells. And this was inspired by work that Steve Schuster had done in patients who had relapsed after CAR T cell infusion, who received pembrolizumab as part of a salvage procedure. And he saw in a couple patients a suggestion that the anti-PD-1 antibody infusion could lead to re-expansion of the CAR T cell with disease control for these patients. So Portia was designed to treat patients who received tisagenlecleucel in a phase 1 design by decreasing the time between CAR T cell infusion and pembrolizumab infusion, with the idea that giving pembrolizumab too soon after CAR T cell might lead to increased toxicity, particularly CRS. So it's a standard 3+3 design with the first cohort of patients receiving pembrolizumab 15 days after CAR T cell, the second cohort of patients receiving pembrolizumab 8 days after CAR T cell, and it recently added a third cohort that receives pembrolizumab a day prior to CAR T cell infusion. The eligibility criteria for this were the standard criteria used in the registration trial for tisagenlecleucel, the Juliet trial. This study has enrolled patients both in US and in Europe. The first thing we did was to ask in these patients whether the infusion of pembrolizumab caused an increased in vivo expansion of CAR T cells. And we did that by serially monitoring the copy number of the CAR transgene by PCR and then correlating that with response. Among the patients who received the day 15 infusion of CAR T cell, there were no complete remissions, and the levels of transgene did not appear to increase significantly after pembrolizumab infusion. Among patients who received the day 8 pembrolizumab infusion, one of these patients achieved a complete remission, but again, no suggestion that the CAR transgene levels bumped up after the pembrolizumab infusion. And I should note that pembrolizumab started on day 15 or day 8, but continued thereafter every 2 weeks. Along with the relative lack of high levels of response, we also saw low levels of CRS and no grade 3 or 4 neurotoxicity. There were some patients who developed infection, but not at a rate unexpected for patients receiving CAR T cell infusion. Cytokine levels, as one might expect, were not particularly elevated in these patients, as they did not have high levels of response. We're currently enrolling patients on the day -1 cohort, where we've shown that pembrolizumab infusion is safe, hoping that an earlier exposure to an anti-PD-1 antibody can further augment the efficacy of the CAR T cells. Certainly in the small number of patients treated to date, 8 in total, our efficacy measurements have been a little disappointing, but I think these were all patients with fairly extensive disease who were eligible for enrollment on a phase 1 clinical trial where there was a appropriate assessment of risk and benefit versus being treated with a commercial CAR T cell. So we're continuing to pursue this hypothesis, and hopefully by next year we'll have final results of this study.